Hey everyone, let's break down one of the most critical skills for nurses on surgical and critical care units, caring for patients with chest tubes. Today, I'll walk you through the difference between pleural and mediastinal chest tubes, and what you need to know to keep your patients safe. First, let's get oriented. Picture the chest cavity in 3D. You've got the lungs, the pleural space, which is a thin potential space around each lung, and the mediastinum, that central area between the lungs housing the heart, major vessels, and the trachea. A pleural chest tube is placed into the pleural space, usually at the mid-axillary line between the ribs. You'll see this in trauma, like a pneumothorax, or after thoracic surgery to drain air, blood, or fluid and help re-expand the lung. A mediastinal chest tube, on the other hand, is inserted right into the mediastinum, typically after open heart surgery, like a coronary artery bypass graft. Its job? To drain blood or fluid collecting around the heart, preventing dangerous complications like cardiac tamponade. Now let's look at a couple of real-world scenarios. Imagine a trauma patient just admitted who needs a pleural chest tube for a hemothorax. And in the next bed, there's a post-coronary artery bypass graft patient with 2 mediastinal tubes draining the surgical site. As a nurse, here are the key care steps I follow. First, check the insertion site for signs of infection or air leaks, like crepitus or bubbling in the drainage chamber. Make sure all connections are secure and the dressing is clean and occlusive. Assess the drainage. For pleural tubes, I watch for sudden increases in bloody output, which could mean active bleeding, or a sudden stop, which might mean a blockage. For mediastinal tubes, I'm hypervigilant for signs of tamponade, like hypotension, muffled heart sounds, or jugular venous distension. Next, I monitor the amount, color, and consistency of drainage. Bright red, rapidly increasing output is a red flag, especially in mediastinal tubes. Any unexpected changes? Notify the provider immediately. When it's time for a dressing change, I use sterile technique, inspect the site, and reinforce the securement device. Never clamp a chest tube unless specifically ordered. Clamping can risk tension, pneumothorax, or cardiac tamponade. Let's compare the two types side by side. Pleural tube, lateral chest wall for air or fluid, risk of re-expansion edema or persistent air leak. Mediastinal tube, subxiphoid or parasternal for blood drainage post-cardiac surgery, risk of tamponade or sudden loss of output. Simulation time. What if the chest tube gets dislodged? Immediately cover the site with a sterile occlusive dressing and call for help. Excessive drainage. Quickly assess the patient's hemodynamics, document, and escalate. Stay alert for complications, breathlessness, hypotension, sudden changes in drainage, and always document your assessments. Chest tubes save lives, but only when managed carefully. Master these basics, and you're one step closer to expert patient care. Thanks for watching. Keep learning, and stay safe out there.